following episode is brought to you by the American Urological Association. This episode features content from the AUA 2025 meeting in Las Vegas. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. This educational activity is supported by independent educational grants from Astellas, Janssen Biotech Inc., administered by Janssen Scientific Affairs LLC, Lantheus Medical Imaging, Novartis Pharmaceuticals Corporation, and Pfizer Inc.
Hey, good afternoon, everyone. I hope everyone is enjoying the AUA, and so glad you're here with us, especially late in the day like this. We'll try to make it worth your while. My name's Judd Mahal. I'm a urologist at Duke University. So now what we're going to do is I'm going to switch into the first, just a brief update on high-risk biochemical recurrence and non-metastatic castrate-resistant prostate cancer. So these are my disclosures. So again, the outline is just a thumbnail on high-risk biochemical recurrence. That's important because of the EMBARK trial that's reported out at the AUA, I guess, about 2 years ago, and is still, I think, kind of a game changer for us urologists. And then non-metastatic CRPC, which is not a new topic, so I'll just give not too much to say about that. So again, this is this is new, April of 2023. The enzalutamide was approved for biochemical recurrence November 17, 2023. So again, the key teaching point, I think most of us know this, that at least in the United States, if you have a patient with high-risk biochemical recurrence without metastasis, you can use enzalutamide either with ADT or enzalutamide monotherapy to treat that patient with high-risk biochemical recurrence. Basically, the background was that this trial actually started about 10 years ago, looking at high-risk biochemical recurrence. It was a 3-arm study. Patients could have received, again, all had high-risk biochemical recurrence, meaning that they had a PSA greater than 1 after surgery or greater than 2 after radiotherapy, and they had to have a PSA doubling time less than or equal to 9 months, and they had to be negative on conventional imaging. They were randomized to luprolide alone, luprolide plus enzalutamide, like combined androgen blockade, and then enzalutamide monotherapy, and followed. The novel thing about the trial is PSAs were blinded to the investigator and the patient, and I was the PI at Duke University, and it was kind of a very interesting trial that none of us knew the PSAs, but patients went along with it, and we went along with it, and it was has been a long-term study. And then at 37 weeks, patients were given a drug holiday if they had a great PSA response. And we were just given letters or told what to do, but we didn't know what the PSA was. So they would tell us, yeah, your patients meet the PSA criteria, you can go back, that you can give them a drug holiday. So a lot of interesting stuff has come out of this. The key bottom line on this slide is, and you can't read this, the arms were kind of well matched between the 3 treatment arms. And this was the primary endpoint, and this was presented at the AUA 2 years ago. Neil Shore presented this at this meeting, and it was a late-breaking abstract, and basically showed that enzalutamide combination gave a better survival than luprolide monotherapy, again, in the setting of high-risk biochemical recurrence. And pretty much across various stratifications, we saw that the combined therapy did better than luprolide alone. And this was looking at the overall survival for enzalutamide combination therapy versus luprolide alone, a hazard ratio of 0.59. I think the other thing that's interesting, or the thing that was most interesting to me, was that enzalutamide monotherapy provided a similar survival benefit to luprolide acetate alone. And so I think many people were surprised. I remember when this was presented 2 years at the AUA, the way it was presented was that this was kind of an interim analysis, and I think many of us maybe expected that enzalutamide would be FDA approved along with luprolide to treat biochemical recurrence, but ultimately the FDA went ahead and approved both. So the point there is that, you know, we have a choice now to use enzalutamide monotherapy or combined therapy with ADT in this setting. This is looking at the percentage of patients who achieved essentially an undetectable PSA. And I find this really fascinating too, because you see 91% of the patients achieved an undetectable PSA with the combination here in orange. Only 67 achieved that undetectable PSA with luprolide acetate monotherapy, and 86% with enzalutamide. So actually the enzalutamide monotherapy patients, if you will, beat luprolide, which I think a lot of us were surprised with. And then this was the median duration of treatment suspension, meaning, remember, at 37 weeks, these guys stopped therapy, and the median time off hormone therapy was 20 months in the guys who were on combined therapy, 17 months on luprolide monotherapy, and only 11.1 on enzalutamide. So, you know, you can argue, I guess you could argue it several ways. While the enzalutamide monotherapy beat luprolide in getting a great depth of PSA response, the duration of off therapy with enzalutamide monotherapy was less than with traditional ADT. So we learned some pretty cool things from this study. The safety profile was good. Again, the key teaching point was that we really didn't see any additional safety issues with one exception, and that is breast side effects. Enzalutamide monotherapy caused an increased risk of gynecomastia and gynecodynia, which is breast pain, maybe not as high as what we had back in the day with bicalutamide monotherapy. But again, the key teaching point, if you use enzalutamide monotherapy in your patients with high-risk biochemical recurrence, and I think it's a great option, I think you should probably refer those patients to radiation oncology to get consideration of prophylactic breast irradiation before starting the enzalutamide. So that's another key teaching point. And again, you see this, the gynecomastia and the nipple pain, I highlighted here with the red box. So just the conclusions on the EMBARK study for high-risk biochemical recurrence is that we have an option. I mean, before these trials came out, we really didn't have any FDA-approved hormonal therapy options for high-risk biochemical recurrence. Now we have FDA approval for both enzalutamide monotherapy and enzalutamide combined with regular androgen deprivation therapy. And again, the data is interesting, and when you apply this to your own individual patients, you know, just be mindful of some of the things we talked about, the duration off therapy and the breast symptoms, but it's a good option, I think, for us in urology to have. So again, we talked about the treatment suspense at 37 weeks. We talked about the quality of life. There was good, and then questions. This is a paper that was just presented at ASCO 2024. The quality of life in the no suspense versus the treatment cess was not clinically or statistically significant. So what Friedland and Shore said on their follow-up study is, even though we did this treatment suspension at 37 weeks, their take on it was that really the quality of life differences in the aggregate were not that much different. So I don't know, what that would suggest is maybe for some patients who have high-risk biochemical recurrence, maybe just continue the ADT and not do the drug holiday. But again, that's kind of speculation on this paper from ASCO 2024. So the second thing, again, very briefly, you know, we've covered non-metastatic castrate-resistant prostate cancer in this course for many years. In fact, this goes back to 2018 when you know, apalutamide was the first drug that was FDA approved for non-metastatic castrate-resistant prostate cancer. So just as a brief review, M0 or non-metastatic CRPC is a rising PSA on continuous androgen deprivation with a castrate testosterone and no metastasis on standard imaging. And at that time in 2018, we didn't have PET scanning. So even then there weren't tons of these patients around, but there were more than there are now. And eventually we had apalutamide, darolutamide, and enzalutamide approved in this space, and they all improved survival. And they all have a similar side effect profile. There's no special monitoring. And at least for urologists who do advanced prostate cancer, this was an opportunity for us as urologists for the first time to get some experience with these drugs. In other words, especially if you were a urologist who only didn't manage metastatic castrate-resistant prostate cancer, as the drug got moved closer to our space in urology, we had the opportunity to use these drugs. And again, the trials were Spartan, Prosper, and Aramis, that all resulted in these trials. They were all published in the New England Journal of Medicine. They all showed pretty much almost identical trial designs and all showed pretty much very similar outcomes. So again, the key teaching point is that all three of these drugs were great to have in our toolbox for that occasional patient who would be in your practice with non-metastatic CRPC. Which treatment you use was really up to your individual discretion, because it was very difficult to show really much significant effect. There was really no difference in outcomes. And these were the adverse events, which were similar. Then overall survival comparison at various follow-ups, again, they all showed, eventually in secondary analysis, showed an overall survival advantage, which was good. But then what happened? Well, M0 or non-metastatic CRPC really is of questionable existence in the PET scan era. So, one of all the questions that comes up is that, well, do I need to do a PET scan if I have a patient who otherwise has traditional imaging? No, you could use these drugs. And for some patients, that may be very appropriate. On the other hand, you might say, well, it's a younger patient. Maybe I want to do spot radiation to that little MET that we find on the PET scan. That might improve the patient's outcome. So again, as individual clinicians, have to make that distinction. If you see a patient like this, are you going to just treat them with one of these drugs or pull the trigger for a PET scan to get a more accurate workup? And I would say this: if the patient is maybe elderly, or if you're not going to use the PET scan information anyway, you could certainly treat with one of these drugs if you happen to see a non-metastatic CRPC patient. But on the other hand, if you think to yourself, well, gosh, this is a younger guy, I want to be very aggressive, then it probably makes sense to get a PET scan, because you might want to do some sort of SBRT at that point. So I think that for the sake of time, I'm just going to end this to say that, PET scan is not required before the use of these three oral agents. PET's findings would not preclude the use of these agents as long as traditional imaging are negative. On the other hand, for healthy men with a longer life expectancy, it may be reasonable to combine these agents with SBRT, although we're still lacking clear level 1 evidence. So we've talked about, in summary, the key pearls: high-risk biochemical recurrence patients with non-metastatic castrate-sensitive prostate cancer with high-risk biochemical recurrence may be treated with enzalutamide with or without GnRH therapy. In M0 CRPC, apalutamide, darolutamide, and enzalutamide are approved along with GnRH therapy. And there are fewer M0 CRPC patients in the era of PSMA PET staging, and more patients already exposed to these drugs earlier. So with that, I'm going to stop and turn the podium over to Dr. Morris. Dr. Morris runs an advanced prostate cancer program in Nashville and is a noted authority as a urologist on this disease. So, David? Thank you. So let's see. Thanks. Okay, I'll let you do it. Thanks.
Thank you. And Judd, first let me thank you for inviting me to participate. And I think we're all lucky to have some top-level educators, including having a noted medical oncologist dumb herself down for the urologist and come help try to catch us up. So these are my disclosures. Basically, as everyone that has a product that's probably touched a prostate cancer patient, usually we've worked with them in some sort of fashion, including clinical trial development. So I wanted to start with a case, and this will kind of sprinkle throughout. Hopefully we'll touch on all the issues related to this poor man who presented now 3 years ago. So this I pulled from my clinic just a couple of weeks ago. Gleason 5+5, PSA 154, obviously had lost his PSA screening at some point, had CT with pelvic nodal disease uptake, bone scan conventional, which was nothing, and then had a PSMA PET with uptake in one spinal lesion and did light up within the pelvic node. So as Judd pointed out, there's a big difference between conventional imaging staging and PET imaging staging, especially by volume definition. So he is technically metastatic hormone sensitive, low volume by PET imaging, technically probably nodal hormone sensitive by conventional imaging because it was a pelvic node, not above the pelvic brim. So with that case in mind, I think it's a perfect time to point out that any of this disease management revolves around multidisciplinary care. And if you can do that within your own urology clinic, that's fantastic. If you have a crosstown company that you can use that's medical oncology, radiation oncology, it's becoming very clear that you need not only that in terms of the primary team, but then honestly, when we get more to what Alicia is going to talk on in a minute, when we get further along this treatment path, we need palliative support, we need hospice transitions. And we as urologists are just starting to touch and learn about all those things that our medical oncology colleagues have learned throughout their training, is that we need to do a better job of focusing on that if we're going to delve into this space of end-of-life of care. So here's our landscape kind of transition from localized disease to terminal disease that's usually CRPC directed. We're talking mainly about these top two buckets, which are newly diagnosed or de novo hormone sensitive or castration sensitive disease, or primary progressive or metachronous, which is a recurrent hormone sensitive prostate cancer that is spread. So several unmet needs I just want to touch on. It's in general, we know that these men are very likely to die of prostate cancer if they're young enough that they don't have a lot of competing risks. We need to do our best to give them the best chance of having that competing risk, which sounds silly, but when we're talking with the patient in front of us, I tell them I'm in a race with your cardiologist, and my job is to keep you around as long as possible so that this prostate cancer isn't the terminal part of your kind of process. Even with all this new data on these medications prolonging OS, we haven't had as much uptake as we've been like. I'm showing newer data this time from kind of the most recent 2024-25 GU ASCO, really trying to point out like we're doing better. We need to give ourselves credit and pat ourselves on the back. It shouldn't be all doom and gloom, but we need to continue to grow. And genetic testing is probably the next thing, and I know Dr. Morgans will touch on that because that's probably our next frontier in terms of trying to do better. So we typically would immediately put people kind of into 4 boxes, and it's related to, are you going to respond to hormone medication or not, and do you have metastatic disease or not? And with those, all these different terms for metastatic, but yet going to respond to hormone therapy, it depends on which body you use in terms of which guideline, whether it's castration sensitive, hormone sensitive, but all of these are basically saying we expect that you're going to have a response to ADT, and we haven't yet formed some sort of castration-resistant pathway of your cells. So initial workup is really around prognosis and extent of disease, because a lot of this goes into choosing the therapy. You have to decide how aggressive we need to be. So that risk stratification revolves around where the METs are located, the number of lesions, and the high volume, low volume. We'll get into in a little bit why that's become important historically. And then along with that, the AUA guidelines here, we should offer germline and somatic testing because it may direct future care. It may not in this initial stage, but it will certainly for family counseling and also for subsequent therapies if they have progression. So in terms of prognostic factors, one of them is timing of metastasis, so de novo versus the primary progressive or metachronous. So those are recurrent disease. That's the line on top. They tend to do better than de novo, even when you're saying volume versus volume. Patients who are presenting right out of the gate with metastatic disease do worse than those who are recurring after primary treatment. When you look at sites of metastasis, this is kind of a combination meta-analysis of multiple CRPC studies, but it's the same sort of idea in hormone-sensitive disease, that lymph node disease only is the yellow line on top. It does best. The bone disease is in the middle, and then the worst prognosis is the visceral disease. Overall survival there, you can see for visceral disease, 16.3 months. So a very short change. It's like half of the duration versus somebody with lymph node primary disease. So really this whole kind of transition in combination therapy started with the Charted and Stampede studies, which are now 10 years old, looking at combination of doublet therapy versus single agent ADT. And there was a 13.6 median benefit at the 50% mark, overall survival benefit for this combination. From the previous CRPC trials with docetaxel, it was a 2-month benefit at the median. So it was a big difference to use docetaxel up front versus saving it for progression. Now, I put the caveat in here that this was great, but it did give us this kind of unruly definition that we now try to use, which is high volume and low volume based on number of bony mets and if there's visceral disease or not. And so high volume, low volume, there's a big difference in terms of the benefits by intensifying therapy, but this is a line in the sand that was created by a clinical trial. So it's unyieldy in a lot of clinical practice. I mean, in reality, you can look at somebody's scan and say, that looks really bad, or this looks less bad. And that's honestly probably just as good as trying to count individual bone lesions, which we all know is fairly made up. If you look at enough bone scans, you're trying to convince yourself that two things maybe are merged and are one thing. So it's not ideal. But in general, we all know visceral is really bad. And if somebody lights up all over the place in their skeleton, that's high volume and it's going to do poorly. So that's great, chemotherapy doublet, but really what we wanted and what the patients wanted is let's avoid chemotherapy, let's use something else. So this oral transition renaissance was really abiraterone as the first step, saying we can really decrease the progression that leads to death by adding an oral agent instead of doing chemotherapy. And the benefits, at least from hazard ratios, were very similar to what was seen with the chemotherapy doublets. You can see the two Latitude and Stampede here, basically abiraterone on top of ADT monotherapy. Big benefit, just as much as was seen with the addition of chemotherapy. Now, there's particular things you have to follow in terms of abiraterone use, liver toxicity, hypokalemia, hypertension, and we've become very versed in this. And I do remember the era when urologists questioned whether or not we would be able to give prednisone and manage any of the side effects that could be associated with it, but I think we're thankfully moving past that. And it's quickly followed by basically every other lutamide had its own OS benefit proof in metastatic hormone-sensitive disease. So Titan for apalutamide, you can see the hazard ratio 0.65, still 40% improvement in terms of risk of death. And the nice thing that I like to point out here is what these curves are doing on the bottom, like where they cross the median, the average patient survival is just slowly moving its way out from 2 years, 3 years to 4 years. So now we're getting out past 5 years when we talk about things that are doublets and triplets. So we've really moved the whole field. Enzalutamide, 2 different trials, both showing the same thing, improvement versus monotherapy. Darolutamide, this is new to add to talk about now. The ARA-NOTE study, which was ex-US, because obviously in the US we're not going to allow randomization to monotherapy ADT versus a doublet, so this was run outside the US. There's no FDA label indication for doublet use for darolutamide. There is one for triplet in combination with chemo. But it is in the NCCN as a lower category offering based off this study, which did show a big difference in PFS. Now, it has not read out for OS because there have not been enough events, but there's the hope with further follow-up that darolutamide would look very similar to APA and enzalutamide in terms of survival benefit. The safety, similar to what Judd just ran through from the non-metastatic CRPC, they're very similar in terms of a lot of overlap. We're used to knowing what to look for now with ADT side effects, and there's really no major differences between any of these in terms of, sometimes the placebo arm looks a little different between the trials, and that just has to do with how the investigators are capturing AEs. And so you see the same sort of slight variance between the side effects, apalutamide, enzalutamide, and then darolutamide with ARA-NOTE as well. So the next question, if 2 things are better than 1, how about 3 things better than 2? And over the last couple of years, there's been 2 studies down there listed at the bottom, ARASENS and PEACE-1. ARASENS was the kind of most recent publication that led to a label approval. And this is what I mentioned in terms of median overall survival. This is kind of adapted from Fizazi presented basically some of this at ESMO years ago. And you can see the steadily progression here from median overall survival from the ADT monotherapy to the chemotherapy addition, abiraterone addition, and then you get to down at the bottom, you've got these three that are adding in chemotherapy. And so the darolutamide and the docetaxel plus abiraterone, that's the PEACE and the ARASENS. So here's the PEACE 1, and it was this standard of care, which at the time was ADT plus docetaxel, and then added in abiraterone as a standard of care plus addition. Now, this is a complicated study that also includes two other arms that included radiotherapy, and so it does get a little bit more complicated to try to cut between these four different groups in terms of outcomes. But in general, adding abiraterone on top of docetaxel did have an improvement versus the docetaxel standard of care arm only. And so you can once again see this median is out to 2 to 3 to 4 years. So we're doing better for all of these patients. That was seen in the de novo patient population only overall. And you can see here standard of care without abiraterone is the lower line, standard of care plus abiraterone is on the top. The ARASENS is the addition of darolutamide as a triplet, and this led to the approval in 2022 for the triplet with darolutamide. Looking at volume risk groups, once again, the same volume story applies even in triplets. There's a big difference, the high volume and low volume on the top, and then underneath that is the high risk, low risk. That's pulled out of the latitude risk categorizations, which are a little bit different than volume. But you can see low volume in the upper right, really not a huge difference between these curves. So, and let's be honest, those patients do a lot better than the high volume patients. So there's a question about how intense we need to be with these patients. If they don't have a lot of competing risk, there's a lot of them that are still alive 4 and 5 years later. So we really need to be more aggressive with the patients who have more aggressive disease. I think that's fairly consistent in all our trials. Docetaxel did not add much to toxicity. It seemed to be a separate toxicity. So you do see the things that we do not want to manage as urologists, like febrile neutropenia. And so that's why we turn it over to colleagues who are very good at getting people through chemotherapy without significant risk to them. And typically this is done in 4 months, and then they're back following up in the urology clinic. So the AUA guidelines basically say you should offer ADT in combination with one of these as a doublet. If you're going to do docetaxel, you really should add in abiraterone or darolutamide. In fact, ADT plus docetaxel fell out of the NCCN Category 1 because these other trials as triplet beat the docetaxel doublet head-to-head. First generation AR blockade like Castrate-Resistant or bicalutamide flare only, not for long-term combined androgen blockade. Dr. Crawford is probably rolling over in his grave out in the hallway hearing that. I mean, I think now we've kind of moved past the first generation to say, like, we need to be
alive.
I know, I just saw him. That's why I'm just saying that. Yes, no, don't go rush and put a poll question on there. So, but ARIs are not recommended really without ADT in this patient group. So as was presented earlier, the enzalutamide monotherapy is not what is intended for this group of metastatic men. And in the NCCN, just in the, I'm presenting it slightly differently than the AUA does, but it's the same sort of thing laid out. They do break it out by low volume, high volume, low volume synchronous. They do say preferred is still the doublet therapy. The low volume metachronous, the lowest risk group, they say the same thing, doublet therapy. So really the triplet is kind of reserved for the higher risk patients. And then there's all these factors that go into saying, is this somebody that we want to try to escalate their therapy? And this is actually a publication from Dr. Morgan's really focusing on the idea of, like, we want to intensify in the right people if they have the right support, if they really buy into it. This is not something we're shoving down their throats just because 3 is better than 2. It's not for every patient. And this was kind of a nice kind of write-up about maybe these are factors that could push you between doublet and triplet therapy. And there's a lot in the gray zone of overlap. But obviously, you may want to avoid chemotherapy in patients who may not tolerate it as well. And then things like different tumor profiling, SPOP mutations suggest you're going to have a great AR response alone. And so adding chemotherapy may add toxicity. On the other side, you see other mutations, TP53, PTEN, and RB1. We're starting to see more and more of those as we do somatic testing on patients up front. If they have triple aberrant prostate cancer and they have mutations in those pathways, they do not do well with really anything that we give them. So those are patients we typically get very aggressive with up front. And you can see the patient factors, it's really kind of younger, more aggressive. Those are the ones we potentially push to chemotherapy. And it may open the door for their next lines of therapy to give them chemotherapy when they're more fit and can tolerate it. And it saves them for later to be able to get other things. So now I wanted to add in a few things that had just come out in the last year. This was from ASCO GU in 2025, a stopgap analysis, which is basically putting together a bunch of those trials. So it's over 8,000 patients. They used trials that included abiraterone and then 3 trials that included enzalutamide and apalutamide. They didn't have 100% data from the lutamide trials, but they did have data from all of the abiraterone trials. And looking at this, they actually did an analysis looking at different age groups, and I think it's kind of interesting to look at the younger age groups did very well with either abiraterone or apalutamide or enzalutamide. If you looked at the older age groups, they did better if they were not on abiraterone. And so, historically, we always thought that has been around a long time. With prednisone, it may be safer for them, but actually, it was kind of a contrary finding to suggest potentially a different sort of approach. And so, I think we're still learning, and we don't have an answer for which medication is right in which patient right in front of us, and it's often a tolerability question. And so, historically, there's been this call to arms that we do a poor job of getting people on therapy. And there's people written in the medical oncology literature and in the urology literature that's almost like looking at aspersions against the other group, like, I can't believe you're not doing this as well as you should. In reality, it's all of us. It's anybody managing prostate cancer. We just need to do better. The uptake initially was not great. And this is some veterans, VA health, where honestly, there's no cost impediment to these patients. They can get almost everything if they're in the VA system. And so when you remove that impediment, you would really hope to see that utilization really takes off, because the cost, which is one of the number one concerns, kind of goes out the window. But this was up through a certain period of time. This was to 2018. So it was still early. This is pre-COVID. This is after the trials had come out, but it was still ADT monotherapy over 50%, and ADT plus a first generation was another percentage on top of that. So it was a very small group, and it's NHT there is the ARSIs. So basically, that's the 26% was getting kind of what we'd say is concordant care. So the real-world treatment has not been as ideal as we would like, and now it is slowly starting to increase. Here you can see kind of this is the guideline recommendation from the NCCN on the right, castration-sensitive, and this is the older version from a couple years ago, basically still saying, look, we need to be doing doublet therapy, and not necessarily chemo. That was a big ask for a lot of these patients. But I do present this in saying this is this was a poster from this past year, and it goes down through 2024 is the furthest over column. And you can really see a decline in the ADT monotherapy group. That's the blue bars that have gone from 75% of treatment in 2013 to 2017, all the way down to now less than 10% in an ADT monotherapy use in 2024. So this is oncology-specific data. That they're doing a great job. Almost everybody's getting doublet therapy. Some are still getting chemotherapy. Some are getting triplet. We need to see that changing within the urology literature. This is a mix of community and academic sites, and this is pulled out of like EMR data, and this was a different poster presenting, saying, look, here's the decline now. Metastatic hormone-sensitive prostate cancer monotherapy was down to 24%. So we flipped from what we were years ago, 75% monotherapy. Now it's the opposite. It's 24% monotherapy. And just selfishly, myself, I look at urology specialty. And, a big component of this data set is urology and community practice. So you can't get numbers to look like this unless the urology community practices are starting to heed the warnings and do what we're supposed to be doing. And so I think that we can pat ourselves on the back and say, hopefully we're starting to actually utilize this like we should be doing, or get the patients to someone who will utilize it if we don't feel comfortable with it. So a couple other kind of caveat special occasions is kind of radiation therapy is taking off. We now radiate everything. We radiate, little spots. We radiate the prostate, even if it's spread. We radiate even in castration-resistant disease. All these things or is this continuity of kind of, is this curable or not? And our focus is different. If we think it's curable, that's fine. If it's widely metastatic, it's palliative. But there's in between, there are things that could maybe prolong time to some sort of event. And so there's been a lot of interest in radiating the primary, radiating the metastatic lesions, even in disease states where we thought it would have made no difference. So the primary treatment, oligometastatic, so this is treatment of the prostate in men who have spread outside the prostate. There's several trials that have looked at this. Stampede, here's this one over 2,000 patients, and you have to squint, but if you squint really hard, you can see there's a little bit of a difference there between the control arm and the radiotherapy arm. But then when you look at the forest plot down below, low burden versus high burden, there was a favoring of low burden disease, so low metastatic burden, receiving radiotherapy to the primary. So it established kind of radiation to the primary as a standard of care. It's now listed in the NCCN as an option. There have been other trials that have since published, HORAD, PEACE-1. PEACE-1, the complicated one with 4 groups, there really wasn't a big difference in radiation therapy outcomes in that setting, but it is now included in the guidelines as an option to consider for radiation to the primary metastatic disease. And then MET-directed therapy is probably the newest thing that's coming. So a couple to present here. STOMP, which was less than 3 lesions on a choline PET scan, which we don't use now. And they were looking at some of the new sort of outcomes that we talk about, eugenatal progression-free survival, or time that you're off ADT therapy. So those are wins for patients. They may not be overall survival, but if you ask a patient, they would say, sure, I might try 5 days of radiation for not having to be on hormones for 6 months. Another trial, Oriole, these are all older, looking at different imaging. So Oriole used conventional imaging, and once again, up to 3 lesions. SABRE versus surveillance. This is progression-free survival. They didn't use intermittent ADT in this study versus the other that did use intermittent ADT. So there's no great data yet. There's still pending trials that are really starting to look at it. Extend went up to 5 lesions, and this could be on FDG PET or conventional imaging. And it was superior to just doing intermittent ADT. So the thought is if you're debulking the disease and removing clones that may become resistant to androgen blockade, that you may get a better benefit out of your period of where you're on ADT therapy. And so this idea of trying to remain off of hormones as much as possible, this has now quickly become taken up in the community, where now my radiation oncologist will radiate anything if it's safe. And honestly, I don't know that I have a problem with that, as long as the patient has been counseled and is willing to accept it. So we typically would say 3 to 5, depending on where they are. We don't like to aim at spots all over the body, but if it's 5 lymph nodes in a smaller packet, that might be something that we would consider doing. So this was presented this year's GU ASCO, the XMET collaboration. So this Wolverine trial, it's like basically taking all these randomized trials, taking their data, throwing them in a pile, and basically seeing what's the benefit out of doing radiotherapy. And you can see regression analysis on the right, the progression-free survival of 50% benefit. Overall survival, there was a trend to benefit. It did cross 1, but there was a benefit to radiating metastatic lesions when you're combining all these different studies together. And just looking at the forest plot here on the left, almost everything is in the area where it's favoring radiotherapy. And so I think that we're learning, and we'll continue to learn, and the radiation oncologists have a bunch of planned trials in this space. You can see all these are different ones that are listed, have not reported out yet. There's even studies looking at prostatectomy, that SWOG trial that's been ongoing for men with limited metastatic disease, to try to say, is surgery just as beneficial for debulking as radiotherapy may be? Now, a couple quick comments on just PSMA versus conventional imaging. I point this out because we're having a stage migration shift driven by imaging technology, and so it's important to keep in mind that not all BCRs need aggressive therapy, and especially after hearing about the EMBARK study saying here we can intensify therapy for men who have high risk of METs. Not everybody has high risk of METs, and so there are people on this curve with failure who even out to 10 years are still alive. And so it is not something where this person is getting ready to die in the next 5 years for the majority of those patients. So we do need to be cautious that we're not just saying we're going to be putting these men on indefinite treatment just because they have some sort of biochemical recurrence. And so that kind of conventional imaging negative, PSMA PET positive is kind of the wild west of what we're going to be doing in our clinics. Just a couple add-ons that are by the guidelines. You should offer genetic counseling and germline. I mentioned that earlier. Germline, obviously, for hereditary and family testing. Somatic tumor testing now, because we have therapies available as next-line progressions, that's usually when we would add them in, and you can get them as soon as they're diagnosed. If prostatectomy specimen, biopsy specimen, archival within the last few years, that often forgoes the issue of having to get new tissue. So back to our case that I presented, imaging with PSMA PET uptake in a bony met, but also pelvic nodes. Somatic testing on the biopsy, no actionable mutation. Germline was negative. TMB was normal. MSI was low. So this is the 90% case. Most of the time you're going to do testing and not find some sort of actionable lesion or actionable mutation. So here he is, low volume, de novo, metastatic. You could argue it's just a nodal spread. It's not even metastatic, but using the PSMA PET, we said that T1 is probably real. And so we elected to kind of do the kitchen sink approach. We take this trial that says we should radiate the primary, so we did. We take this trial that says you should do MET-directed therapy to the lesions if they're amenable, so we did, to the boost to the nodes and also SBRT to the T1 lesion. And we did 2 years of combination ADT plus abiraterone. And so, this was 2022. Now it's 2024. He's coming off his abiraterone. His PSA nadir to 0.02. And 4-month follow-up, still 0.02. T is not recovered, so that's the next frontier of what we're going to try to do for these men, is try to get them back to having normal testosterone. But I think this is someone that, as long as his PSA is stable, we feel comfortable saying we're going to surveil you and can reinstitute care if it's needed. We've theoretically, with curative intent, treated everything that we could see. So a couple just bolt-ons that go alongside metastatic disease. What about bony health? The basics are vitamin D and calcium, like exercise, real life activity, getting up off the couch. I live in Tennessee, so it's hard to convince people that we need to get up and get moving. And that's something we kind of push because it's the easy thing to do. There are a lot of anti-resorptives. My experience with those is I tend to save the ones that are expensive for people with castration-resistant disease. They were never really studied in hormone-responsive disease. And so I don't just immediately throw people on full doses of denosumab because they have bony mets. I've used a lot more of the cheap alendronate bisphosphonates in those patients just to try to maintain bony health. And I think that saving that more expensive therapy, which is often more expensive than even their ADT agents or their ARSI agents for out-of-pocket cost, is a wise thing to do, just to be cautious. On the horizon, just to point out a couple of things, because you'll actually see signs for this even out in the exhibit halls. So if you've never heard of P10, you'll probably hear about it in the next year. So the Capitello trial, an AKT inhibitor, so looks at P10 deficient tumors. So there's this potential triplet that would use capivasertib in the hormone sensitive disease up front. They have had a press release. It did improve PFS. The OS obviously is not mature. It is not. It's probably coming soon to a major conference, I would imagine. PSMA addition, it's basically lutetium that is moving to kind of the frontline therapy in combination. It's completed enrollment, so there's a lot of excitement about getting a readout on those. So kind of here's graphically, this will be in the slide deck. If you're looking through it at a later time, it kind of describes. But for many of these things, we still have to do the other things. We have to test for P10. If you're talking about doing PSMA addition, they've had to have some sort of PSMA PET scan that can identify if they have uptake, and you have to do some sort of evaluation on how much the SUVs or how much uptake versus the liver background or the bone or the blood pool background to get an idea of how aggressive you think you want to be. For all of those, there's also the contrary to that, which is basically, can we suspend treatment just like they did in Embark? Can we get a good response from metastatic patients up front and then potentially back off of therapy? And so Aristep is one that's with darolutamide that's also using PSMA PET in part of the screening. So it's trying to become a next generation trial and trying to basically give us the option to take away therapy if people have good responses. Talipro-3 and the next one I'll present, we're coming to the combination PARP world, and Alicia's going to probably tell us all about what's already available, but those things are coming for metastatic upfront, whether it's Talipro, whether it's Amplitude. Those are probably the soonest to read out, and they will look at PARP inhibition addition for men who have mutated or even non-mutated patients up front. And so there's a lot of interest in the combination of PARP inhibitors with ARSIs because it makes the cell, at least from a in the science lab. It makes the cell act like it's more PARP dependent, so it gives it a BRCA-ness that's been argued, and we're still yet to really see how much that's true in the patient world, but those will be coming. So this is obviously we just now are celebrating 15 years of Provenge and Dendreon with the Sipuleucel T on the market. So it's been a renaissance over the last 15 years with almost a drug approved every year. And so the next phase is going to be now here we're going past 2010, and it's all of these medications. And from beyond, we're starting to see like these are the trials probably coming in metastatic hormone sensitive. There's an addition of other active surveillance studies. There's high-risk localized studies. These are all reading out in the near term. And so thankfully, a lot of them are using the same tools that we're used to. It's just applying in a different patient population. So hopefully we don't have to learn a whole new set of side effects, toxicity management, and that sort of thing. So kind of our conclusions, ADT monotherapy should be a no-go. Unless you've got somebody who's 92 years old, and honestly, that may have to be monotherapy. But I would say if I had to guess, our goal for monotherapy, you should be around 10%. It should not be 40%. It shouldn't even be 30%. And it may be intensified therapy for a short term and then down to monotherapy, but it really should be isolated for the frailer patients that we're not trying to intensify therapy. Doublets and triplets available. You need to do some sort of risk stratification, high risk or low risk, low volume, high volume, and then you need to be more aggressive with high volume patients. Radiation to the prostate if you've got low volume metastatic disease, radiation to the metastatic lesions if you don't have much spread. That's been supported in multiple early phase studies and now is being hopefully confirmed in more high level studies. Germline testing is recommended for all patients with metastatic disease. Somatic goes along with it. Germline is actually recommended also for the high volume or the high risk localized disease. So Gleason 8, 9s, and 10s, we're honestly seeing a lot of those patients have PSMA like avid lesions that we would have never really seen with conventional imaging. So it's shifting the idea of what is high-risk localized versus metastatic, but you should be getting testing up front on these patients. Bone health should be part of it just because we're going to be committing them to potentially years of ADT suppression. We're going to bring on osteoporosis in some of our frailer men. And then clinical trials, if they're available in your market, or if you have a great academic center across town, patients should at least hear. There's a lot of things being tested. If you're that sort of patient that's inclined, I always encourage patients to look into it. That's the reason that we have these medications available for all our patients, is because some were willing to say, I'm gonna give that a shot. So with that, I think I managed to bust through an entire session really quickly, hopefully. Keep us on time.
Great job. Let's take just a couple minutes for questions. Does anyone have any questions for Dr. Morris or myself on the first two presentations before we move on to metastatic castrate-resistant prostate cancer? Yes, sir.
Actually, I have two quick questions. That's all right. The first one is, with EMBARK and Aricept showing cessations in treatment about 3 years or so, what's the current thought about, like, even though Dr. Schwer's study showed if their quality of life isn't impacted, continuing on, that having breaks lengthens the time to castrate resistance. So if they have recurrences, being able to put them back on and then delaying castrate resistance. And then the other is with triple therapy now, are we worried that we're throwing the kitchen sink up front, but we're losing our second, third line options? So it's kind of an all or none unless they have a HR mutation, and we can do, PARP inhibitors, at least for now, until some of these other drugs are moved earlier.
Great question. Maybe I can just take the first one on EMBARK. Great point. That's not been reported out yet as far as what the long-term implications. EMBARK is, we're still following these patients on the EMBARK trial, but it's interesting. Recently the Pfizer folks and the Astellas folks, obviously detail on that now, and I found it interesting. I don't know if the other faculty is that they're not really even pushing monotherapy. I mean, at least when my rep called on me, they said, well, why don't you just use combination therapy? So I'm not sure why, from an industry standpoint, they're not necessarily, at least for me, they weren't really pushing the monotherapy. And that's still a confusing point to me is, if I have a patient with high-risk biochemical recurrence, how do I really know whether I should use combination therapy or enzalutamide monotherapy? And I was just
My
maybe a-
2 cents is I limit monotherapy for people who have voiced a strong opinion that they would love to stay off ADT. It's usually people who had ADT with radiation therapy, and they're like, "You're never putting me on that again."
That's a good point.
And that's now thankful to have an option that includes not using ADT. And so that's been in my experience. I mean, the combination is better. I mean, like it is a stronger effect than enza monotherapy. And I have worried about some of the breast toxicity. Unfortunately, the breast toxicity also overlaps with the age group that might be the people that are complaining about having to go back on ADT. So I don't, Alicia.
You want to comment on that?
Yeah, I think that the patient preferences, as you kind of said about side effects, absolutely come into play, and there are people who say, I just won't go back on androgen deprivation therapy. I do think, especially in older people, if they also prefer to have a non-castrating option, that maybe there's some better maintenance of their muscle mass. And I think that there need to be studies to help us understand that a lot more clearly. But having high testosterone just causes different side effects, not necessarily no side effects. So it can be challenging.
If you want to do the second one,
the second question was about
triple.
Well, I guess well, now I'm confusing myself. So what was because
I think it was, if you do triple therapy, are
do
you
you
losing your
lose
options
something?
for future treatment, right?
Yeah, because your talk is basically going to be about that. I mean, I think until lutetium was approved in a pre-chemo space, that was an argument that I made to patients, that like triplet therapy up front, and that would be your next option available. Now that it's moved in front of docetaxel as an option, your point is a valid one. I think Dan George would argue like very few people go on to get line 3, line 4. And so at some point, some people say like, just use your best bullet first. And so I'm hopeful that if you use the strongest therapy for those high-risk patients, they're so at risk that they're going to develop a problem in the near term, and they're probably going to develop a problem. And docetaxel is not going to necessarily be any better for them down the road than it is up front. And I'm hopeful that I just kick the can far enough down the road that our next MOA drug is approved, and that maybe it's not BRCA-directed, but maybe it's something else. That's my 2 cents. It's a great question, though.
Sir.
Yes, thank you, Dr. Mull. I always enjoy the session. David Yee from Sutter Health, and you mentioned, Dr. Morris, metastasis-directed therapy. I was always curious, like if you had a patient, they had treatment, either radical prostatectomy, and then they develop biochemical recurrence, and then you catch them with maybe a couple bone lesions on your PSMA PET CT, and the radiation oncologist, decides to do metastasis-directed therapy. How long do you leave them on androgen deprivation therapy? And how long do you leave them on the androgen receptor, ARSI? So that's the big question.
That is a great question. That is a data-free zone. So it is. I mean, honestly, you could ask me on a Monday, and I'll give you a different answer on Tuesday. It's very patient-directed, I think, is what you'll hear from all of us. I think anywhere from 6 months to 2 years is reasonable. I mean, if you want to follow the guidelines, they're metastatic. They could be on it forever. So I typically will do it at least 6 months and then really judge how upset they are with the therapy. Some people want to get off, and I just say you're probably going to have to go back on. Other people probably have been cured, and some people surprisingly don't want to come off because they like the fact that their PSA looks so low. So then it really turns into, I have to judge how risky they are. If I really think they're cured, like with salvage, I would love to get them off the medicines. These are not great for them long term. So I mean, 6 to 12 months, I'd be interested to hear what
This was the biggest point of contention in the ARISTEP study design. So this was patients with a maximally treated pelvis who then had BCR but had a PSMA PET positive, at least they could have up to, I think, actually maybe there's no limit, on the number of lesions. There's an expectation that all these patients will get SBRT. That study is designed with 24 months of ADT plus or minus darolutamide, but initially it was designed as 12 months, and there were people who said they wanted indefinite. So it just went back and forth and back and forth. I think the ultimate reason that it went with 24 months is because the Presto trial reported out with a 12-month duration of therapy that had just a very brief PSA progression-free survival advantage with this addition of apalutamide and with ADT. And so the thought was we probably need a longer duration of ADT to make a meaningful difference in terms of potentially curing some patients if that's the goal. And I think that is the goal when we have these PSMA PET positive lesions. If there's an opportunity for us to eradicate all of them, that's the goal. So there's no answer.
Okay. Thank you.
I was going to give a shout out. He's coming to the microphone now. So I want to recognize Dr. Larry Karsh. Larry is a noted urologist and personal friend. And in this course, I think, you were talking about Provenge being around since 2010. I think we've had this course since so this is about the 15th anniversary of the course. And Larry was one of our esteemed faculty for quite a number of years. So I'm so happy you came back. Thank you.
Really continuing this course, it's great. Thank you. And I always learn something. Now with PSMA PET, we're doing that, and we see patients that have nodes all the way up to supracapitular nodes. So do we consider those low volume if they're just nodal only? They go all the way up.
Yes.
Yes.
But I think that we are very eager to have a molecular kind of understanding of what might really drive the prognosis that we currently are associating with low volume disease. We're counting up spots and then we're just putting people into prognostic buckets, but there have to be biologic markers and drivers that we will over time be able to pull out in each of these and really understand better. As an example, the Decipher score was recently shown to actually potentially be associated with benefit from chemotherapy in metastatic hormone-sensitive disease if people had a high Decipher score. So this is, one step forward in trying to understand. It's not just high volume number of spots on a scan. Maybe there are these molecular tests that we ultimately will be able to do. But yes, lymph nodes, it doesn't matter how many or where they are, they're low volume.
And so are there any genetic markers that you look at now, like somatic testing, that would make you think this patient isn't going to do so well?
I think that we will be looking at P10 very shortly because we'll have a new therapy, this AKT inhibitor, capivasertib, that will be directed there. And P10 is generally considered to be associated with a poorer prognosis. But right now, we are not using any of those tests to make treatment choices around what our therapies are going to be. But I think this is going to change within the next, 1 to 3 years. We'll be thinking about it very differently.
I do look for RB, TP53, and P10 and SPOP, although I only have a handful of SPOPs. But if they have one of the tumor suppressor genes loss, we, even regardless of volume, will typically do a consult requesting triplet therapy.
Interesting. Good. Larry, thank you very much. And I just want to ask David one final question about what's the deal with why did they find that ABI might have been a disadvantage for older patients? Do you have any? I know it's speculation, but do you have any thoughts on that?
It was all speculation, and you were there, and the discussants were very upfront, saying I don't know that this was really expected, but it makes me think about our assumptions of what we have done for a long time. When you get more data, we shouldn't just always stick to the assumptions that we've had for 10 years just because we've had them. And I think it was eye-opening for me to say, there's a lot of other competing risks that we don't fully grasp. We just always felt like the lutamides were almost harder on their function with frailty and brain interaction because abiraterone appears to be pretty well tolerated from most of our patients. So it was just strange to see that in analysis. And it's the only time that I've seen anything presented like that. That's the reason I presented it here, because we don't just need to accept that all my lutamide patients look like they tolerate it poorly with fatigue. That must be worse for an 85-year-old. That data suggested no, it actually is better for them. And I don't know what they couldn't suggest why.
The final point I want to make for you gave an excellent talk. The take-home pearl that low volume metachronous hormone sensitive is doublet, because in other words, for the urologist, we have all patients in our practice and we've been followed for years. Those were the guys who we followed and they progressed to metastatic disease, but it's still low volume, especially PET. We don't want to overtreat them.
No, I think that is in fact, what's weirder too about the risk factors in terms of progression, even the high volume metachronous, even those who recur after therapy with higher volume, do better than the low volume synchronous. when you analyze all the trials, Chris Sweeney did a nice analysis of all it. So if you're synchronous de novo disease, you do worse, regardless of volume, than basically the correlates and the metaconus. But even the ones that are discordant, the high volume, low volume, synchronous metaconus, like there's an overlap. Like the de novo outweighs the volume of disease. Like as she mentioned, that volume is just kind of a line in the sand that we've created. And whether it's looking at PSMA PET volume uptake, I mean, there's things that have looked at, because it should not use the PET imaging to calculate volume at all. So you have to use conventional imaging.
Not yet.
But they've looked at, what are they going to say? Like, we're going to do a volume metric analysis of how many spots are lighting up and then say this volume considers itself to be a higher volume. There's several things that are at least been proposed. So.
Well, great. Thank you very much. We're going to move on to advances in metastatic castrate-resistant prostate cancer. Dr. Morgans from Harvard is going to update us on the latest advances. Thank you.
Great, thank you. And thank you, everybody, for sticking around, because I know there's a lot to do out there. It seems like a fun city. So thank you for being here for just a bit longer. So we're going to go through some general principles in metastatic castration-resistant prostate cancer. We'll talk about some recent therapeutic advances focusing on PARPs, radiopharmaceuticals, and then we'll wrap it up. I'm certainly happy to have conversations and questions at the end, but we really just tried to focus on some of the more recent updates. And as we heard, there have been many new approvals. And also, there's actually been an approval that I'll mention, but is not even noted in this deck as being an approval because the deck was submitted months ago. And this approval came about 2.5 weeks ago. So let's talk about some general principles. So these are the NCCN guidelines for metastatic castration-resistant prostate cancer. They are intimidating, to say the least, and challenging to read unless you're right up in front of your screen. But the main point of these is that we have so many options, and it's really important for us to think about where the patient has been in terms of their prior treatment, so we really understand the best options that might be available at this point in time. And I think that for urologists, these top two boxes may be a little more commonly considered because these are the no prior docetaxel boxes and include patients who've really only had ADT in the upper left and patients who have had ADT and an AR pathway inhibitor on the upper right. And we'll try to break it down a little bit. So try to blow it up, but the basics, if you've only had ADT before, are that you can add an AR pathway inhibitor, which is probably the most common thing that we're going to do in this first line MCRPC setting. You can use chemotherapy, docetaxel in this case. You can consider a PARP inhibitor if patients have an HRR mutation with or without an AR pathway inhibitor, and I'll go through the single agent PARP data as well as some combination data. We'll talk through what those indications are. HRR mutations is just a broad bucket, but each of the combinations and single agents can actually have some specific recommendations that might be a little bit narrower than that. And then to blow up the prior ADT and AR pathway inhibitor, just the general concepts here, most commonly used options, probably docetaxel. Consider a PARP inhibitor for patients with HRR mutations, and I've listed that as a single agent, though one could argue maybe you could consider combinations, especially if you're changing your AR pathway inhibitor. Radium-223, Sipuleucel-T, one that we can now consider that's not on the list because of this recent approval is lutetium-177, PSMA-617, so also called Pluvicto, now just approved before chemotherapy. So would it be added here to the list? And I don't know if it's made it on the guidelines yet because, as I said, that's been about 2.5 weeks. I also put an asterisk here because I think one of the most important things for us to keep in mind is that evidence really suggests repeatedly in control arms of trials that are used to develop therapies for MCRPC that a second or alternate AR pathway inhibitor typically provides limited benefit, sometimes PSA stabilization or mild decrease, but usually radiographic progression within 3.5 to 5 months. So generally, this is not considered to be an especially effective strategy for most of our patients. So our clinical factors are still key, and this is something that I know is actually quite a laundry list, but this is why we still have jobs, because we get to think through all of these things and then help to kind of think through that chess game that is ultimately the way that we find our next treatment, and then the next and the next and the next. So the number one thing here is what I alluded to on the last slide, that novel mechanism of action is really going to be preferred here. And then we have to think about, where is the disease? Are there visceral metastases? Are there bone-only metastases? And sometimes this can give us opportunities for certain treatments and not others, depending on where things are. How is the cancer progressing? Is this a highly symptomatic patient who may be in visceral crisis or have cord compression and really needs to have an intervention immediately that is a strong and rapidly effective intervention? Or is this an asymptomatic patient who has a PSA rise, maybe one new area of bone metastatic disease, really not symptomatic or having any clinical progression? Is the patient a candidate for chemotherapy? And this is something that medical oncologists think about all the time. There are calculators online that one can use, especially from the CAR group, which is an older adult group that looks for toxicity development in older adults with cancer and exposure to chemotherapy. But in general, in medical oncology clinics, I think many of us really use the ECOG performance status to make that assessment, as well as considering patients' bone marrow reserve, whether they have neuropathy, whether they have other organ dysfunction, especially as it relates to specific chemotherapeutic agents. But in the case of docetaxel, those are the ones that we generally think about. We also have to think about whether there is small cell or neuroendocrine differentiation, because this is a branch point where we're not going to use an AR pathway inhibitor or maybe radium-223, but we're going to use a platinum-based combination chemotherapy approach. And especially when there's a disconnect between the PSA and the volume of metastatic disease, as an example, or new progression in the liver, or something that looks clinically very atypical for prostate cancer, we want to think about a repeat biopsy, because a neuroendocrine or small cell differentiation diagnosis is going to be made on histology. We don't yet have a circulating biomarker that says that patient has small cell cancer. So have to get the biopsy. We have the conversation with the pathologist. If it says small cell prostate cancer, that's immediately a platinum-based combination chemotherapy, unless the patient is unfit. And I think really interestingly, it's not a topic for today, there are new therapies that are being developed and have been approved for patients with small cell lung cancer that we are now, in some patients, using off-label for their second and other line therapies in this setting. Moving on down, are there targetable DNA repair defect mutations, deficient mismatch repair mutations? Does the patient have MSI high status? And actually, did I do the genetic testing to find all this information? Because obviously there are going to be PARP inhibitor and pembrolizumab opportunities there. And then very practical things like, do I actually have certain therapies available in my clinic? Do I have the staff available to try to put together a multidisciplinary team to deliver a radiopharmaceutical? This is absolutely important. And as we heard from David, clinical trial options and thinking through where we might send patients and have collaborative communication with different physicians in the area or in the region can be really important, especially when it comes to MCRPC, which is incurable. And our patients appreciate, I think, when we try to help them find the opportunities like clinical trials that may benefit them. So just to really hammer this home, I think we've mentioned it already, but genetic testing is a standard of care in metastatic castration-resistant prostate cancer. And this is because DNA repair defect genes and these mutations are quite common. In this initial analysis, about 23% of patients had DNA repair alterations. And the frequency of these alterations increases in populations as they progress through MHSPC, certainly from localized to metastatic disease, and then metastatic HSPC to CRPC. We can see on the right-hand side a distribution of different mutations that were pulled out, with BRCA2 being the most common. And this is actually just all a metastatic prostate cancer population, demonstrating that germline genetic mutations were present in just under 12%. And it's because that threshold really exceeds 10% of a population that we generally think that germline genetic testing should be performed in all patients with metastatic disease. And one important concept here is that that's not only patients who were diagnosed with prostate cancer at a young age or patients who have a strong family history. It is regardless of both of those factors, given the prevalence, because it was not associated in that analysis with either of those things that we traditionally think might give us an enriched population for patients having these genetic alterations. So here we see the AUA guidelines. Genetic testing should be offered to patients with metastatic CRPC if it has not already been done. And the NCCN guidelines also suggest this, really suggesting germline testing for any patient with high-risk localized, very high-risk localized, or metastatic disease. So really important for urologists to keep that in mind. And if germline testing has not been completed by the time patients develop metastatic CRPC, it should be done either blood-based or saliva-based testing. And if somatic tissue or ctDNA testing has not been completed, this should also be done for patients with mCRPC, so germline and somatic. And why do we want to do both? Well, we do know that different mutations are going to be identified with our different tests. They are present in different rates in these different tests, even within the same patient. So among all BRCA2 mutations, again, the most common, we'll see about half of them are identified in as somatic mutations, half as germline mutations. PALB2, which is considered to be maybe nearly as responsive to PARP inhibition as BRCA2, is actually identified more commonly in somatic testing. At the bottom, we can see MSH2 and MSH6, also more common in somatic testing. And this is one of the best markers for patients to actually have a response to pembrolizumab, because these are Lynch syndrome type genes. And I've found actually better responses when I have these genetic mutations than when I have TMB high, which actually doesn't seem to correlate with response to pembrolizumab in my patients, at least very frequently at all. But MSH2 and MSH6 mutations, as well as MLH1 and PMS2, all actually have quite strong correlation. So to get into the PARP inhibitors, these are the drugs that we're using to target those DNA repair defect alterations. They are approved as both combinations and have been approved for several years as single agents. And the first study that led to an approval was this PROfound trial, which assessed olaparib for patients with mCRPC. And all patients coming into this trial had DNA repair defect alterations, either BRCA1, BRCA2, or ATM, and those patients were grouped into cohort A in this trial, or they could have had one of another 12 different HRR mutations. That was cohort B, really an exploratory analysis looking into these less common but potentially important alterations. All patients came into the study after having been exposed to an AR pathway inhibitor, and they could have been exposed to docetaxel, and they were randomized 2-to-1 to receive olaparib versus the alternate AR pathway inhibitor, enzalutamide if they had had prior abiraterone, or abiraterone if they'd had prior enzalutamide. The primary outcome here was radiographic progression-free survival in cohort A, and then secondary outcomes are also listed here, including overall survival. So here you can see that progression-free survival in that trial, the total trial population, so A and B, clearly demonstrating a benefit to treatment with olaparib versus the alternate AR-targeted agent. And I would share that the median progression-free survival here for the alternate AR pathway inhibitor is about 3.5 months. So really basically the time to the first scan. So I think this is important for us to remember, again, that switching our AR pathway inhibitor is generally considered a pretty ineffective treatment option, which was reiterated here in the PROfound trial control arm. But the olaparib patients had a substantially better PFS, and they also, in cohort A, that was the BRCA1, BRCA2, and ATM population, had an improved overall survival, as we can see on the figure on the left, with the olaparib treatment being illustrated in the blue curve, red curve underneath, demonstrating the alternate AR pathway inhibitor overall survival. On the right-hand side, you can see the overall cohort A and cohort B. This did not reach statistical significance for overall survival, but the approval for this drug actually does cover all of the HRR mutations that were included in that analysis, except one. So PPP2R2A is actually pulled out as a mutation that actually those patients seemed to have poorer outcomes in terms of PFS. So you do not want to give olaparib to that particular patient population. And I've seen one in my testing over the last number of years, and put a big note in my chart to tell me, do not use a PARP inhibitor in this patient, or at least do not use olaparib, because strangely that in exploratory analyses, that patient population seemed to do worse. In any event, we have a second PARP inhibitor approved as a single agent in mCRPC. That's rucaparib. Its initial approval being designated after the Triton-2 study, which is actually a phase 2 trial, single arm, in which patients had HRR mutations, and they were enrolled in this trial after having exposure to docetaxel and an AR pathway inhibitor. And I'm going to focus on the BRCA1 and BRCA2 alterations because that's where the indication ended up coming out, although you can see other genes were included in the initial analysis. All patients in this MCRPC single-arm trial were treated with rucaparib 600 milligrams twice a day, and we had a RPFS endpoint. So here we can see on the left the RECIST change from baseline, demonstrating in patients with BRCA1 and BRCA2. Those are the only mutations included in this presentation. That a majority of these patients had a decrease in size of their tumor, but in terms of measurable disease. And on the right-hand side, this is PSA response, also demonstrating quite a pronounced PSA response during treatment with rucaparib. Now, they had a subsequent study that was really bolstering that approval. So they were approved on the phase 2, but then did have to complete the phase 3 trial to keep that approval. And the patients in this study had had prior exposure to an AR pathway inhibitor, but had chemotherapy-naive MCRPC. They had BRCA1, BRCA2, or ATM alterations, and you can see that they were randomized to treatment with rucaparib versus physician's choice, which could be the alternate AR pathway inhibitor, but it could also be docetaxel. And this is the first study that really looked at a comparison of a randomization of a PARP inhibitor versus chemotherapy in a BRCA1, BRCA2 population, which I think is really important as we sort of think about sequencing and think about opportunities for these patients with these targetable alterations. The endpoints here, primary endpoint, radiographic progression-free survival, with secondary endpoints including overall survival. So here's the radiographic progression-free survival in the BRCA subgroup, which is again where the approval for this agent is, and you can see the RPFS clearly favors rucaparib treatment versus the physician's choice, that composite control arm. But I think really importantly, we can see in this curve on the upper left, this is the randomization of rucaparib versus docetaxel. And very importantly, this is the only study that we have at this point in time, at least, that shows that treatment with a PARP is clearly superior in a selected population to treatment with docetaxel. So this is something I absolutely keep in mind when sequencing these agents in these patients, because you want to get the PARP to these patients as soon as possible, and you would absolutely favor a PARP over treatment with chemotherapy. On the right-hand side, we can see the rucaparib randomization with the AR pathway inhibitor, also favoring rucaparib in this setting. Again, not an especially effective control arm here as an alternate AR pathway inhibitor. Here we can see the breakdown by patients who had BRCA mutations on the left, but this study included BRCA1, BRCA2, and ATM. So you can see the ATM mutation patients on the right. And also quite clearly, patients with an ATM alteration did not seem to benefit from treatment with rucaparib as compared to the composite control arm. So ATM is not necessarily a subgroup that I usually consider treating with a PARP, at least as an early line treatment, and it's not covered in the approval for rucaparib here. But you can see the BRCA patients did benefit. And here is the overall survival data from Triton-3, which did not find an improvement in overall survival in this particular randomized population. And this also is not something that's necessarily surprising because we do have a composite of BRCA1, BRCA2, and ATM as the patient population, and also these patients got subsequent therapies. So as we are moving all of these treatments into earlier and earlier spaces, we as a field have to think about our understanding of and a willingness to rely on an RPFS endpoint rather than overall survival, because with subsequent therapies and all of the unknowns that come into play, it can be really hard to see an overall survival benefit in these populations with earlier and earlier treatment, as we will discuss with our radioligand conversation. So the PARP inhibitors here, we can see approved rucaparib for patients who have BRCA1 and BRCA2 alterations after treatment with chemotherapy. Olaparib is for patients with any of those HRR alterations, except for the one that I mentioned. And this can be after AR pathway inhibitor treatment. It can be pre or post chemotherapy. There's no restriction there. And now to get into the PARP combinations, which are the more recently approved agents. So PROPEL was a first-line mCRPC patient population treated with ADT. They could have had docetaxel in the MCSPC or HSPC setting, but not in the mCRPC setting. And all of these patients actually came in as an all-comers population. So some of them did have, a portion of them did have HRR alterations, but an all-comers population was enrolled, and they didn't prospectively sort patients into having these HRR mutations or not having them. But they were randomized to treatment with abiraterone versus abiraterone and olaparib, and they were followed for radiographic progression-free survival. At the time of this study, there was previous phase 2 data that suggested that a wild-type population may actually have a large amount of benefit from that combination of olaparib and abiraterone, and this is why they enrolled everybody from a feasibility standpoint based on that primary data to have that randomization before the HRR status was known, which is different than one of the next studies that I'll talk about. So here we can see the radiographic progression-free survival and the intention to treat population. This is demonstrating the benefit of treatment with olaparib and abiraterone versus abiraterone alone. And I would say that really importantly, abiraterone is a highly effective control arm in this setting. So these patients had basically ADT alone in the MHSPC setting. So the next standard of care would be treatment with abiraterone. So to beat the abiraterone, I think you had to do something differently, which makes this a little bit more impressive. Here we can see the overall survival data, really intention to treat, suggesting that there was a numerical 7.4-month difference between the two groups in terms of overall survival, favoring abiraterone and olaparib versus abiraterone alone. But this did not yet reach statistical significance, and not all of the events have occurred. So we will see another time point on this further follow-up. So TALAPRO-2 is the next study in line. Actually, there will be a third. There were 3 total studies that led to an approval here of a combination, in this case, talazoparib and enzalutamide in first-line mCRPC. So this included patients, actually an all-comers population, but as patients were entering this study, their HRR status was known and documented, and they were placed into cohorts based on that. And so, again, all-comers population, but their HRR status was known. Patients were not exposed to prior treatment with enzalutamide or with a PARP inhibitor, could have had abiraterone or docetaxel if they had it in the metastatic hormone-sensitive population, but all the numbers were quite small in terms of those exposures. And you could see here that they are randomized 1-to-1 to receive enzalutamide, which is a highly active control arm in this setting, versus enzalutamide and talazoparib. And the primary endpoint here is radiographic progression-free survival. Here you can see rPFS by that blinded central review favoring the combination of talazoparib and enzalutamide versus enzalutamide alone. Again, highly active control arm, so this was actually very impressive. And here we can see by HRR status, so they're HRR deficient, or those patients with a mutation on the upper right, showing a very clear benefit in terms of radiographic progression-free survival for the combination versus enzalutamide alone. And the HRR non-deficient or unknown also suggesting a benefit here in radiographic progression-free survival. We can see subgroup analysis by genetics really showing a very clear benefit in terms of BRCA1, BRCA2 on the top, but other groups also seeming to benefit, though some of the confidence intervals are wide and do cross the null there. And I think importantly here, and very thought-provoking, was the overall survival data presented for the overall whole total all-comers population at GU ASCO 2025, suggesting a statistically significant benefit in terms of overall survival for the combination of talazoparib and enzalutamide versus enzalutamide alone. So where this ultimately will go, I don't know, but I think this was very thought-provoking and not necessarily expected after what we saw in terms of lack of statistical significance in the all-comers population and the FDA's approval and decision around the other agents. Here we can see the overall survival by HRR status, obvious benefit here for the combination of BRCA mutations and then HRR mutations other than BRCA1, and this was just presented at GU ASCO as well, suggesting benefit in these subgroups. And so the magnitude study is the last that I will do, and in this combination option or combination setting. This is also first-line MCRPC. These patients did have their HRR status known going into this particular study. They were put into cohort 1 if they had an HRR mutation. They were put into cohort 2 if they did not have a mutation. So just another strategy here of how to make that happen. And within each cohort, they were randomized to treatment with niraparib and abiraterone versus abiraterone alone. Again, abiraterone alone in this previously untreated population they did not have an ARPI previously. This makes abiraterone a very strong control arm. Importantly, cohort 2, which was the HRR negative cohort, did not have a benefit from that combination treatment versus abiraterone alone, and this was stopped for futility. But cohort 1 did have a clear benefit. So here's radiographic progression-free survival for cohort 1, specifically in the BRCA subgroup, and you can see the combination of niraparib and abiraterone superior to the strong control of abiraterone alone, and this did lead to the approval of this combination abiraterone and niraparib in patients with BRCA1, BRCA2 in that first-line MCRPC setting. And here's the overall survival and secondary endpoints demonstrating that the overall survival, at least as it was an intention to treat, did not necessarily show a benefit, but they did do some analyses adjusting for various factors that did suggest that there might be an overall survival advantage to that BRCA1, BRCA2 subgroup. And so before I get to radiopharmaceuticals, just to emphasize, niraparib and abiraterone approved as a combination for patients with BRCA1, BRCA2 mutations. Olaparib, abiraterone approved in the first-line MCRPC setting for BRCA1, BRCA2 mutations. Talazoparib and enzalutamide actually approved first-line MCRPC for HRR mutations, all of the ones included in the study. But I think the conversation is ongoing now that we have this overall survival data as to whether the enzalutamide talazoparib indication may ultimately be expanded, and we'll see. So to get into radiopharmaceuticals, VISION is the registration trial that led to the approval of lutetium-177 PSMA 617, also called Pluvicto. This included a heavily pretreated patient population with MCRPC who had had cancer progression after treatment with an ARPI and with chemotherapy, docetaxel chemotherapy, or additional therapies as well. They were randomized after PSMA PET identification of them having PSMA PET avid disease, 2-to-1 to receive lutetium PSMA 617 plus the best supportive or standard of care versus best supportive or standard of care. The best standard of care arm for many patients was the alternate AR pathway inhibitor, but other options included pain medicines, steroids, bone health agents. Patients could not receive radium, cabazitaxel, immunotherapy, PARP inhibitors. The reason was that they did not have safety data with that best supportive, all of those different best supportive care options and concurrent treatment with lutetium-177 PSMA 617, which was given in that treatment arm in combination with best supportive care or best standard of care. So this was the rationale, but it is an interesting and important control arm to understand. The primary endpoint here was an alternate primary endpoint of overall survival and radiographic progression-free survival. And importantly, treatment with lutetium PSMA 617 did appear to improve both overall survival and radiographic progression-free survival as compared to that best supportive care arm. And the safety data suggested that we do need to watch for cytopenias because this is a radiopharmaceutical. It can cause some bone marrow suppression. It also can cause dry mouth because of the uptake of the agent into the salivary glands that also express PSMA protein, as well as some fatigue and nausea. Therapy was a phase 2 study that was done also looking at lutetium PSMA 617 in the setting of a comparative analysis between a randomization to that versus cabazitaxel in patients who had MCRPC and prior exposure to docetaxel. So it was really trying to understand which is better, Pluvicto or cabazitaxel in patients who are heavily pretreated. About 90% of patients had prior exposure to an AR pathway inhibitor, but this was not required. This study was run in Australia and New Zealand. Again, it's a phase 2, and the primary endpoint here is PSA response rate. Here we can see that treatment with cabazitaxel was inferior to treatment with lutetium PSMA 617 in terms of PSA response greater than 50%, with the waterfall plot favoring that treatment on the right, which is lutetium PSMA 617. And also importantly, the overall survival curves for the randomization are completely overlapping here, suggesting, at least in this phase 2 study, which is not powered to find a survival difference, there was no significant difference here. I think there was a fair amount of crossover. There are a lot of reasons for this, but it also may be that these are both reasonable options for treatment, which is how I interpret this data. And especially when there was a shortage of lutetium PSMA 617, it gave me some comfort to know that I can give them chemotherapy now and hopefully give them the radioligand therapy later and not lose any ground. One of the other things that we think about in terms of choosing between treatments is whether there might be a biomarker or some way to help us understand we should give lutetium PSMA 617 earlier or later. We don't have that necessarily, but we do have some data that suggests that some patients may have a more robust response to lutetium PSMA 617, and that's SUV mean. I think importantly, SUV mean, which is literally sort of a quantification of the SUVs of all of the spots that can be seen on your PSMA PET. This is not typically a clinically delivered bit of information. You do have to ask your nuclear medicine team to give it to you if you really are on the fence, don't know if this is the right treatment for your patient. But it is something used in research right now and is not clinically reported. But what we know is that patients in the study, which this was the VISION trial, who had an SUV mean greater than 10 seemed to have a more substantial benefit from treatment with lutetium PSMA 617 than those patients who had lower SUVs. And you can see that they kind of fall in line here with it's almost like a dose response. Obviously not dose response, it's SUV mean response, but it very much follows the degree of uptake. And all of these patients seem to, as a cohort, have some benefit from treatment, but it's interesting the degree of treatment did vary. So maybe we will be using this at some point in the future to help us decide on next treatment. And as we start to wrap up here, PSMA-4 is the study that was looking at and has looked at patients with mCRPC who have not had chemotherapy but have had exposure to an AR pathway inhibitor. Patients in this study were randomized 1-to-1 after identification of having PSMA PET avid disease to receive lutetium PSMA 617 versus the alternate AR pathway inhibitor. The primary endpoint here was radiographic progression-free survival, and at the point of progression, patients in the control arm could cross over and could get lutetium PSMA 617 per the trial, so they didn't have to go find it in their community. And I think that's one of the reasons that we were able to see this trial accrue, because we know that the control arm here was probably inferior, being the alternate AR pathway inhibitor, but patients could get access to Pluvicto as soon as they progressed. Here we can see the radiographic progression-free survival primary endpoint clearly favoring treatment with lutetium PSMA 617 or Pluvicto versus that AR pathway inhibitor change with a hazard ratio here of 0.49, so strongly favoring it. And we do have updated overall survival data, which does reflect a high degree of crossover from patients in the control arm who crossed over and got lutetium, essentially showing us that you get lutetium now, you get lutetium later, you're going to have similar benefit in survival. And so this is something that's now actually approved as of just a couple of weeks ago in the pre-chemotherapy space. And I think very much worth a conversation with patients about whether they want to get it now as their next treatment versus after chemotherapy. I didn't show the quality of life data, but patient-reported quality of life data does suggest that many patients do prefer this treatment option. And I think we'll continue to see safety data, which is the other thing we think about in terms of bone marrow suppression, cytopenias, and potential development of things like AML. We do not have any indication that the bone marrow is suppressed for a long period of time for the majority of patients, or that there are other complications from cytotoxic effects on the marrow, but we will continue to see. But this is now approved. And I've forgotten about PACE3, so we'll get this in here too. Radium-223 is still around. This is a bone-targeted calcium mimetic agent, alpha-emitting agent, which is in contrast to the beta-emitting Pluvicto. That means it's a higher energy than a beta, and it travels a very short distance, 6 to 10 cell lengths away from where it's integrated into the bony matrix as a calcium mimetic in the system. This study, PACE3, it was just reported at ESMO, included patients with mCRPC who actually had bone metastases but were asymptomatic from them, which is different from the ALSYMPCA trial, which led to radium-223's approval many, many years ago at this point, over at least a decade. In any event, asymptomatic, and they could have had lymph node involvement as well, no visceral disease. Importantly, patients were treated essentially with ADT, potentially also with chemotherapy in about 30% of people. They were enrolled and they were randomized to treatment with radium-223 plus enzalutamide or enzalutamide alone. Also importantly, patients were given a safety letter that said you must use a bone health agent to prevent skeletal-related events during this combination treatment, because a study that was running just a few years before this called ERA223 that included patients with MCRPC treated with radium plus Abi versus Abi alone found actually a high rate of fracture throughout the entire study, but a much higher rate of fragility fractures in the combination arm. That study was unblinded so that they could understand why, and it looked like the lack of use of bone health agents in that study contributed to the high rate of fracture. So patients in this study had to use bone health agents. It was mandated. The primary endpoint here was radiographic progression-free survival. Here we can see about 30% of patients were treated with prior docetaxel. Nearly nobody had abiraterone. They could not have had enzalutamide. And the RPFS here for this randomization shows that enzalutamide plus radium significantly prolonged radiographic progression-free survival as compared to enzalutamide. Enzalutamide in this setting, first-line MCRPC in a patient population that has not received an AR pathway inhibitor, is a very strong control arm. So this doing better is actually quite significant here. Hazard ratio 0.69, highly statistically significant. This combination also improved overall survival. So if you have patients who have been treated with ADT alone and now are in first-line MCRPC and you're thinking about enzalutamide, you may consider thinking about adding radium because it improved overall survival. Only 80% of the survival events are in, but it seems like a stable number, and it is certainly a statistically significant number. We'll get further follow-up on that. Time to first symptomatic skeletal event was not different between the arms, and the safety data looked like additive safety issue, only no additional safety concerns other than the ones we are already aware of with radium and enzalutamide. So to wrap this long talk up, and again, thank you for your patience. Treatment of men with MCRPC does continue to evolve. Multiple studies that I presented today and things that we talked about actually have just developed in the last weeks to months, so very, very rapid change. Our general principles still hold true. Do not sequence AR pathway inhibitors unless there is a compelling reason to do that. That is not expected to be especially helpful. Germline and somatic genetic testing are really a standard of care, so do them. These tests can identify patients who might have HRR mutations that can be targeted by PARP inhibitors, either single or in combination. Lutetium PSMA 617 is an option after docetaxel and an AR-targeted agent, but as of a couple weeks ago, actually, after only progression on an AR-targeted agent, you do not have to get chemotherapy first anymore. And radium plus enzalutamide prolonged RPFS and OS in first-line MCRPC, so maybe an option for you as well. Thank you.
I'm going to do the post-test questions, if that's okay, yeah. What we got to do yet is the post-test questions, and then certainly we have some time for questions for Dr. Morgans. So I need to go back in here and start, okay. Okay, I need the post-test question file. There we go. Let's see. Again, while we're getting this up, does anyone have a question we can just do to save time? Does anyone have a question for Dr. Morgans? Larry, you want to come to the...
You don't get to ask any more questions, Larry.
So, I mean, now we have this embarrassment of riches. We've got so many therapies. How do we sequence them? Let's say that wild type for talipro 2, that gets approved as first line in the wild type. So, you enzalutamide and talipro. Now you have piece 3. So what would you do? Would you do the piece 3 and then add talazoparib after they get the radium, or just wait till they progress? Or, I mean, this is going to be interesting to see, where we go with all this.
That is a very interesting question. I like your suggestion. Give some radium, then give the talazoparib. That's really interesting. Whatever you do, add a bone health agent. That's also really important, as we heard from.
And I remember because we did the AUA2025 trial, and they stopped it.
Yes.
And for the reasons that you talked about. And at the time, they were at a point where they were thinking about stopping piece 3.
Oh, yes.
They decided that, they're going to make it mandatory that people went on, that the patients went on bone targeted agents, and then they went through, and completed the study.
Yeah, and I think it's so interesting that it looks like the effects, certainly they had equivalent SRE rates, which were generally pretty low, and the effects of radium must be a disease control effect. It's not that it's just not causing these SREs. These were equivalent. So it's really quite a fascinating study, but I'm glad they didn't stop it. And I don't know the answer to your question, which one do you do?
I would pose another question on top of your question, because the real problem is I hope we're doing a better job in treating those people with a combination up front.
Yes.
And those patients were not in either one of those studies. So to make it very clear that TALA-2 patients had not been on years of agent leading up to that enrollment, and the same for piece 3. So
but
it is truly uncharted.
Abby,
they were allowed, like 2%.
On Abby, not a apalutamide.
And I don't think they could have progressed on Abby. They could have been on it for a short period of time.
If they progress on Abby, now they're metastatic castration-resistant.
Yeah, but
They would have started in the metastatic hormone sensitive, and then once they progressed, they were castration-resistant.
But people are definitely asking the question, if they had ADT and Abby in an earlier state and now they're in MCRPC, should we switch to Enza and then give talazoparib? I think there are so many questions that have come up, and as we saw from your discussion of metastatic hormone-sensitive disease, there are many more trials that are going to be reporting out in MHSPC soon. Maybe we do need to ask the computers how to help us do our jobs.
Why?
That was
Why
a
do you
joke.
think
Handle it.
why did TALAPRO-2 show? And as Larry said, I like your term of the wild type. We haven't used that since back in the lab, but basically for the audience, what he's saying is these guys did not have an HR or a BRCA mutation, yet the PARP showed a survival, but yet in magnitude with the other PARP, there was nothing. Why?
Yeah, I think people think there may be some differences in these PARPs, and also a different partner, right? So enzalutamide versus abiraterone. I don't think these are easy answers, but there may be differences in the drugs that could be driving it. Plus, these were separate trials; they were enrolled in separate places and separate institutions. It's really difficult to do a cross-trial comparison, but between different populations and different drugs, I think that may be it.
It comes down to trial design, but the futility study for magnitude, they stopped it at a year, so you don't know if those patients, if they stayed on, if they would have.
True, because PSA progression would have counted as a progression event. So there were a lot of conversations around, did they stop it too soon because they really relied on PSA instead of radiographic progression?
To add insult to injury with all this data, now we have real-world data that's FDA, with these FDA rules surrounding it, where we're seeing, David, you didn't discuss that today because that's a can of worms, but, trying to pit one AR versus another, and with this real-world data. And we'll see more of that as AI comes into play on all these gigantic databases. So stay tuned. I guess we'll have to continue to run this course for a couple more years.
Yeah. Greatest course at the AUA.
We got to do the one more question, and we got to do the.
Glad you made that point about the PSMA 4 study, because the overall survival, there was no difference. So I'm glad you made that point that there was the crossover that really caused that. Because I was going to say, well, maybe we shouldn't be using it before, use it after, because there was a survival benefit after docetaxel.
Large amount of crossover, a huge amount of crossover.
So,
yes.
okay, well, thank you.
Thanks. One more question, and we'll do the post-test.
Dr. Morgan, it's just a question for you. Now that lutetium is moving earlier in the pathway with chemo-naive, is there any utility in certain situations of an FDG PET? Because I've sort of heard this where the PSMAs may be under characterizing disease, especially with lutetium. When would you get that in what situations before moving forward with lutetium?
I actually favor CTs with contrast. So if you do CTs, chest, abdomen, pelvis with contrast, you'll actually have a better characterization of the liver because your PSMA PET is going to be a sink for the dye. You don't get a good characterization of your liver. And you'll be able to follow your CTs over time to assess for progression. If you will be able to see, if you're using contrast, you're able to see disease, and then you can talk to your nuke med. Are the sites that I see on my CT really those that are overlapping with my PSMA PET? And that should be sufficient. At least I think a lot of us in practice are doing that because there are concerns about getting an FDG PET approved. Also, there's not universal expression there's not universal uptake of FDG for all lesions either, and so you may be missing things. But a really nicely done standard CT with contrast can actually I think can be easier to obtain and potentially more informative and useful over time for looking for responsive progression.
No, we've utilized it only in cases of weird neuroendocrine sort of dedifferentiation, sort of. That's the only time we've thrown in FDG if the PSMA is totally negative and there's all kinds of weirdness happening.
Agreed. I do have a patient with mixed histology of adeno and small cell, and so I get FDGs on a regular basis because I'm specifically looking for that small cell component or these atypical.
Yeah.
So anyway, thank you very much. Appreciate our faculty for doing a great job. Thank you guys and gals for coming and staying till 6 p.m. in Vegas for this. We really appreciate it, and hope you have a great rest of your AUA and safe travels home. Thanks. And if you're going to the AC/DC concert tonight, be careful.